Hello, welcome to SGT University. I am Dr. Shikhar Ganjoo, Faculty of Medical and Health Sciences, and today we'll be learning about vitiligo. Vitiligo is characterized by well-defined depigmented macules with scalloped margins. The lesions of vitiligo are chalky or milky white in color. Vitiligo happens due to the absence or decrease in the number of melanocytes. Vitiligo can happen at any site on the body, but happens more on the pressure points. As we can see in the picture on the right, the lesions are concentrated on the knees and on the ankles. In this picture, the lesions are concentrated on the elbows. There are two patterns of vitiligo. The first is segmental vitiligo and the other one is non-segmental vitiligo. These are two pictures showing vitiligo patches. The picture on the left shows the depigmented macules on the palms extending onto the flexor aspect of the forearms, whereas the picture on the right shows the depigmented macules on the knees extending below onto the extensor aspect of the leg. There are many hypotheses why vitiligo happens in an individual. The etiology of vitiligo. 20% patients have a positive family history. The second is the autoimmune hypothesis, in which the presence of antibodies is seen to melanocytes. The third is the neurogenic hypothesis, in which a toxin is released from the nerve endings that destroys the melanocytes. Now, coming to the classification of vitiligo. The vitiligo can be localized, in which the various subtypes include focal, segmental, mucosal, and lip tip. Vitiligo can be generalized, in which the various subtypes include acrofacial, in which the lesions are present in the acral areas of the body, for example the tips of the fingers, and the facial areas such as the lip tips and around the eyelids. The second subtype of generalized vitiligo is vitiligo vulgaris. The third subtype of generalized vitiligo is universal type of vitiligo, in which the entire body is involved by vitiligo and there are only a few areas of the body which are not involved. Now coming on to the focal vitiligo, in which small isolated pigmented lesions happen without any segmental distribution. As we can see in the pictures on the right, there is a vitiligo depigmented macule on the eyebrows and another lesion is on the front of the knee. Coming to the segmental vitiligo, in which the lesions are characterized by dermatomal distribution. The lesions never cross the midline. Mucosal vitiligo. In this, the vitiligo patches are seen over the oral and genital mucosa. In the lip tip vitiligo, the lesions involve the lips and the genitals plus the fingertips, as we can see on the picture on the right. The acrofacial vitiligo is characterized by macules in distal digits, in the periorificial areas and the facial areas. Vitiligo vulgaris. This is the most common type of vitiligo. It usually starts in the second decade of life. It is either slowly or it can be rapidly progressive as well. Usually there is a family history present in such patients. Vitiligo universalis. This is the least common variant of vitiligo and is of extreme severity. The clinical features of vitiligo can be described as a round, oval, or milky white depigmented macules with scalloped margins. Leucotrichia occurs in a few patients. The leucotrichia means that there are white hair that result from reduction or absence of melanin in the hair follicles. Now coming to the differential diagnosis of vitiligo. The various disorders that can simulate a vitiligo include piebaldism, pityriasis alba, pityriasis versicolor, leucoderma, or Hansen's disease, also known as leprosy. The aim of treatment in vitiligo is to induce repigmentation starting from the hair follicles. Now, coming to the treatment. The aim of treatment is to induce repigmentation, which can be done using phototherapy or use of steroids. These therapies also remove the Langerhans cells which are responsible for destruction of melanocytes. As we can see in this picture, within the depigmented macule of vitiligo, there are certain areas of repigmentation happening in the center. Another picture showing the depigmented macules over the lower abdomen and the inguinal region with various areas of repigmentation within the depigmented macules. A few points about phototherapy in vitiligo. The phototherapy can be a topical therapy or it can be a systemic therapy, but both are given on alternate days. In topical therapy of phototherapy, there's an ointment or a lotion which is applied to the depigmented macules of vitiligo, following which a half an hour gap is given before which the patient is exposed to sunlight. The best time to expose to sunlight is between 11 am to 1 pm. This form of phototherapy is known as Mucosal. In systemic therapy, the patient is given oral sorolins in a dose of 0.6 mg per kg body weight, following which a 2-hour gap is given before which the patient is exposed to sunlight. This form of therapy is known as PUA or Sorolin and UVA. The patient should be protected from sun after this therapy for about 8 hours. The time of sun exposure is gradually increased till a mild erythema in the depigmented macules is observed. The other modalities of treatment of vitiligo can be categorized depending on the extent of disease. In a localized disease, whether the lesions are new or old, we give topical steroids, topical Sorolin or UVA or Mucosal. In extensive disease, in new lesions, we give oral steroids, may or may not be combined with PUA or Mucosal along with narrowband UVB. In patients who are intolerant to PUA or narrowband UVB, oral steroids are given. In patients who have generalized lesions or vitiligo universalis, the remaining areas of normal skin are removed by monobenzyl ether of hydroquinone to give an even look appearance in the skin. In patients who have less than 20% body surface area involvement, the modalities of treatment include steroids, calcipotriol, tacrolimus and topical PUA, and these are all topical therapies. In more than 20% of body surface area involvement, systemic PUA is given, oral steroids and narrowband UVB is preferred. In patients in whom surgical modalities of treatment can be given include skin grafting for stable vitiligo, split skin graft and a punch graft. Today we discussed vitiligo. Next time we'll learn about melasma. Till then, keep learning, keep growing. See you next time.